first time for me to be physically present. It's really an honor to be among this nice present group, and also an honor to be to meet Professor Dimitris Goulias from Greece for the next time. Professor Goulias, welcome again to Egypt. I'm glad that the Alexandria team, you have met distinguished speaker yesterday, Professor Ali Al-Agouri, Professor Maha Bondo, Professor Tamer Al-Shirbini, and Dr. Ahmed Al-Hamid. Thank you for their cooperation with Asthma. I heard that the session yesterday was very strong. لي نص سلايد من فوق. ما تخليش انا مش هعدل بس شيلين البتاع فوق سامحني. شلت كله؟ لا مش السلايدز مش كمان. Okay, anyway, I've chosen this interesting talking because bronchial asthma and thyroid disease are very common. So that's why we have to know how to deal with the thyroid and bronchial asthma. And in the next 18 minutes, I will be speaking about 5 important points and questions. First, is there an association between thyroid disease and bronchial asthma? The second, what are the effects of thyroid disease on bronchial asthma? And what are the effects of thyroid disease treatment on bronchial asthma? Fourthly, about the effects of bronchial asthma treatment on thyroid. And the last one, can thyromegaly or goiter mimic bronchial asthma? Let's go through the track. عندك مشكلة في عندك مشكلة حضرتك مش مقاسات السلايدز نفسها. الوقت ده محسوب يا توريان. Okay. كده شكرا جزيلا. Now, first I will be discussing, is there an association between thyroid and bronchial asthma? Yes, indeed, because both of them, they have got a common autoimmune soil. You know that from the medical school, you remember that we've got 2 types of bronchial asthma, T2 because of the T2 cells, and this is called also extrinsic or allergic asthma, and the non-T2 asthma, which involves T helper 1 and T helper 17 as well. So you can see that in the different publication, there was association between thyroid antibodies that were more common in patients with bronchial asthma. This is a common soil, and this publication was from Iran. You can see a patient with asthma, the percentage of positive antibody 25% higher than the normal population. Another publication also was this from Egypt, from Ain Shams. You know, Professor Fahmy Abdelaziz from the University of Ain Shams. They did a publication showing again the patient with bronchial asthma, they have a higher rate of autoimmunity. Not only that, also from mania. It was very interesting from Dr. Hala Muhammad from the chest department, showing that again, the TPO was higher even in the non-allergic asthma. Remember, the non-allergic was at non-T2. Non-T2, the antibodies were higher than the allergic. And lastly, from the AZI as well, and we are a very interesting publication from the AZI from Dr. Riham El-Shabrawi. This is from microbiology and from internal medicine. Dr. Naem Rashad, I don't know if she's with us today. Very showing again that patients with bronchial asthma have got abnormality in the gene polymerase for TPO. It seems that this is very interesting. And I'm writing this publication to show that in Egypt, we've got many international publications. So this is very encouraging for all us, for the juniors, and also for the seniors to continue their publication in the, and was discussing Professor Demetrius that now international publication is very, very costly. But anyway, congratulations for this Egyptian publication. Let's go to clinical. Is there really clinical association between the thyroid? Yes, in this interesting study from Taiwan on 45,000 patients. In Taiwan, we got plenty of material. They show that the incidence of hyperthyroidism is higher in patients with bronchial asthma than non-asthmatic patients, 16% versus 12%. And further, the risk of hyperthyroidism is more if it occurs in a patient below more than the age of 30 years, and if there is a recent asthma. So again, hyperthyroidism is more common in patients with bronchial asthma. What about hypo? Yes, the risk of hypo is more, and you find this study from China, 19,000 patients with asthma, huge number of patients, showing there is a statistically significant increase of hypothyroidism. And now let's shift to the second question. Is there any effect of thyroid disease on the bronchial asthma? So if you will get hyper or hypo, was going to affect? The answer is yes, because as early in 1944, there was early publication that patient with asthma, if they get hyper, they will get worse. And we got several publications showing the same. This asthma and hyperthyroidism, this 1972, more recent publications showing stated asthmatic and patient with bronchial asthma with hyperthyroidism, and again having acute severe asthma with thyroid crisis and myasthenia. And when I was an intern or house officer in the late 1970s, I have seen a patient with asthma. And when he developed hyperthyroidism, he got worse. And I was really astonished because we have been taught as medical students that in hyperthyroidism, the sympathetic system is over. So I expected that the bronchial asthma will improve with hyperthyroidism. And this was not the case. And when I reviewed the literature at that time, I found some few publications. Now the publication is getting stronger. Even that, they definitely show that when a patient with bronchial asthma will get hyperthyroidism, it will be more difficult to treat. You need to increase the dose of steroids, increase the dose of bronchodilators, and asthma will improve by giving antithyroid. And even he can get worsening of the asthma in case of relapse. So remember this association. Hyperthyroidism can worsen asthma. What about the response to the salbutamol? The response to salbutamol is negatively related to T4. So the higher T4, the less response to the salbutamol. Please remember that in your clinical life. Again, the possible mechanism first is that reactive oxygen species in hyperexaggerated. And this will induce autonomic imbalance, leading to more muscarinic receptor contraction and less beta-adrenergic dilatation. It will also increase the microvascular leakage, leading to increased mucus secretion. So remember the reactive oxygen species. Another mechanism, patient with thyroid psychosis, that is increased clearance of hydrocortisone. That's why you can get a worsening of the bronchial asthma. The third mechanism is the prostaglandin. With hyperthyroidism, there is more metabolism of the prostaglandin. That's why you can go worsening of the asthma. So there are three mechanisms. What about hypo? Actually, when the patient with asthma will develop hypo, most of the data say the asthma will improve. And if you give them thyroxine, the asthma can worsen. Please, this is a very interesting observation. And in this publication, say caution. You must be cautious when using correcting hypothyroidism in patients with asthma for the risk of exacerbating of the bronchial spasm. And the mechanism is very confusing because some of the mechanisms say it is due to the lack of eosinophilic infiltration with thyroid. These are experimental on rat, and these are the patients, sorry, the rats here. Rats after thyroidectomy, you get the eosinophilic infiltration of the mucous membrane is less. And when they corrected the hypothyroidism in these rats, the number of eosinophils get worse. And this is one of the mechanisms why patients with hypothyroidism, if you start treating them, they can worsen. The third part of my point to be discussed is what are the effects of thyroid disease treatment. And of course, you know, this gentleman with typical Graves' disease and beta blockers are actually indicated. And you know, for medical school, the beta blockers to the beta 1 effect is good for the heart, lowering the tachycardia, but the beta 2 effect is bad. So it's this case is either use a super selective or use calcium channel blocker to diminish the tachycardia in this patient. Fourth point is the effect of bronchial asthma treatment on the thyroid. Does it have an effect? Yes. Steroids. Can a steroid affect thyroid? Yes. You know, again, the steroid can lower the level of TSH, so central mechanism. So remember that. Secondly, the steroid will diminish the conversion of T4 to T3. So in this case, the T3 then gets down. And less commonly, if used steroids for a long term with high dose, it increase the production, what we call the thyroid binding globulin from the liver, leading to a decreased T4. So remember, TSH lowering is not uncommon with, this is a clinically important question. Secondly, is the diminished conversion. And thirdly, which is very, very uncommon to have this diminished TBG. Another drugs commonly used in the دواء التركيبة, in use تركيبة رقم 1 رقم 2, as you know, and we don't know what is the تركيبة. You find that, but mostly they put steroids and they put iodides. So iodides in the syrup used to treat patients with bronchial asthma can lead to problem with thyroid. Of course, in this interesting publication, you can show that the antibodies with higher patient taking iodides, and especially if there is iodide-induced goiter, and especially again in the intrinsic asthma. Intrinsic asthma, this is non-T2, non-allergic asthma. And there were several publications that hypothyroidism can complicate prolonged use of high dose of iodine, and the mechanism that you expect that if you give iodine, get excess, but this is not the case in these cases. This is what we call the Wolff-Chaikoff effect. If you give more iodine, there's adaptation of the thyroid gland to tries to stop this mechanism. That's why you get hypothyroidism. On the other hand, you can get also with potassium iodide hyperthyroidism. And I remember when I was maybe a lecturer or assistant lecturer that in Alexandria, at a certain time, they were giving all the schools, children and students some excess iodine to avoid iodine deficiency. Actually, there was a flare of hyperthyroidism at that time. So remember, potassium iodide excess prolonged use can lead to hyper. This is called the Jod or Yod-Basedow effect. Lastly, can thyromegaly, can goiter present as bronchial asthma? The answer is yes. I remember one of the cases actually was referred from a very famous chest physician in Alexandria, and he picked it up, although that there was no apparent goiter. There was no apparent goiter. So you can see the different publication. You can get really endotracheal ectopic thyroid. Sometimes the thyroid cannot be not only in the tongue, but also can be in the trachea, as you see in this publication. And this will lead, you see, this is the trachea and this is the ectopic thyroid. It will lead to tracheal compression. And also the famous retroexternal extension. Again, retroexternal extension, and sometimes you don't see the thyroid by neck examination, even by the distinguished examiner. And remember that obstructive retroexternal goiter can mimic bronchial asthma. If you get on cystoscope, you will be hearing the wheezes, and even the patient will complain of the wheezes, and you need to suspect it. And this is one of the patients with retroexternal extension. You can see this is the trachea is narrowed by the thyromegaly, and this is after removing the thyroid. You can see during endoscopy the tracheal is back. So during my short presentation, I've tried to to answer the 5 questions. The first, is there an association between thyroid disease and bronchial asthma? Yes, that can occur because of the common soil autoimmune problem. The second, can the thyroid disease have an effect on bronchial asthma? Yes. Hyperthyroidism, worsening of the bronchoconstriction. Hypothyroidism, ladies and gentlemen, the الشباب اللي ورا, I will be eager to just, this is for you. The hypothyroidism can improve the bronchial asthma. And if you start giving thyroxine, you should be aware that I can call you, doctor, your medication provoked the asthma. This is correct. This is not the patient advice. So again, remember that. Thirdly, that the thyroid disease treatment, of course, you have to avoid, you know that beta blockers in patient with bronchial asthma, you know that. And fourth point, that the medication used to treat asthma, like steroid, will affect the thyroid, lowering of the TSH, lowering of the conversion of T4 to T3. And lastly, you have to remember that a big retroxynal goiter, even if you don't see it clinically or feel it clinically, particularly in elderly patients, it can present like a bronchial asthma. So we have to remember that all the time in our practice. And thank you very much for your coverage.